Hello everyone. Welcome to my presentation titled Machine Learning Driven Analysis of Pneumonia Patients. In this project, I analyzed pneumonia patients' data using statistical techniques and machine learning methods. I focused on exploring vital signs patterns, applying PCA for dimensionality reduction, clustering patients into groups, and examining differences in survival outcomes. In the next slides, I'll walk you through the data, the methods used, and the key insights from the analysis. Before starting the imputation process, I first extracted the data from the PIC database using PostgreSQL. The vital signs and lab measurements I used for this analysis include temperature, heart rate, respiratory rate, pain score, systolic, diastolic blood pressure, and lab items such as WBC count, bicarbonate, monocytes. Because these variables were stored in different tables within the PIC database, I used SQL joins to merge them into one consolidated dataset. After combining the data, I first removed the patient's records with more than 20% of the missing values. This is done to maintain the data quality. I then checked the normality of each variable using Shapiro-Wilk test. And since most of the distributions were non-normal, I had to use Mann-Whitney test for statistical comparisons. For missing vital sign values, I used medium imputations, which is appropriate for skewed clinical data. For WBC counts, I created low, medium, and high categories and applied stratified imputation within each group to preserve the clinical meaning. As future work, I would like to extend the stratified imputation approach to other vital signs to improve the accuracy of the missing values. Here you can see the results of the normality test for all the vital signs used in this analysis. I used Shapiro-Wilk test, and as we all can see, the p-values are below 0.05. This means none of the variables follow a normal distribution. Heart rate and systolic pressure are closest to normal, but still statistically they are considered normal. Respiratory rate, diastolic pressure, and especially pain score show very high skewness and kurtosis, indicating heavily tailed distribution and extreme values. Because of the lack of normality, I used non-parametric methods such as Mann-Whitney U-test, and I imputed the missing values using medians instead of means. The pain scores are not very consistent, are not recorded for all the patients. Hence, I removed pain score for further analysis. Why I chose Mann-Whitney U-test is because the vital signs were not normally distributed. So I chose a non-parametric test here. We divided the patients into two groups, alive and deceased, to compare differences in their vital signs. Using Mann-Whitney U-test, we assessed whether each vital sign varied meaningfully between these two groups. Out of all the vital signs, respiratory rate was the only metric showing a statistically significant difference, indicating that patients who died tended to have more abnormal or elevated respiratory rates. We can clearly see that the respiratory rate for the deceased, the median value is 53.93 compared to the alive group median, which is 40.66. Other vital signs like temperature, heart rate, systolic pressure, diastolic pressure did not show significant differences between the groups. Overall, this analysis highlights respiratory rate as a key vital sign associated with a high mortality risk in this cohort. I'm showing the cluster results for the vital sign data using the k-means algorithm. On the left is the elbow method plot, which helps determine the ideal number of clusters. We see a strong bend at k is equal to 4, meaning after 4 clusters, the reduction in inertia slows down. So adding more clusters gives less improvement. On the right, you see the PCA visualization of the clusters after removing the outliers. Here we considered 3 standard deviations away is a outlier. PCA reduces the high dimensional vital signs data into 2 components so we can see the clusters visually. Each color represents one cluster. The grouping shows that the data naturally forms around 4 main clusters. Even though the silhouette score for different K values are close, K is equal to 4 provides the best balance between the cluster quality and interpretability. Clinically, 4 clusters also make sense because patient vital sign pattern tend to fall into few broad physiological groups. Here you can see a bar chart, alive versus deceased per cluster, and a heat map showing the mean vital signs per cluster in this slide. This bar chart compares survival outcomes across clusters, highlighting which patient groups have high mortality risk. Heat map on the other side shows how key vital signs differ by cluster. It helps to identify the physiological patterns linked to high mortality risk. Across the floor clusters, overall survival rate remains high, but notable differences emerge when comparing mortality and vital sign patterns. Cluster 0 shows the lowest mortality of 4.5%, which relatively stable vital signs and with minimal physiological stress. Cluster 1 demonstrates the highest mortality of 10%, driven by most abnormal vital signs of high heart rate, elevated respiratory rate, significantly low blood pressure, a pattern suggestive of systematic stress and early shock. Cluster 2, which shows 10% mortality just like your cluster 1, but it displays elevated HR and RR respiratory rate, but with moderately preserved blood pressure. Cluster 3 has an intermediate mortality of 7% with moderately elevated heart rate and respiratory rate. Overall, as vital signs become more emerged, specifically when heart rate is high, respiratory rate is high, and blood pressure is low, mortality increases, supporting the clinical usefulness of clustering. As part of future work, I would like to expand this data set to improve more stability and reduce the class imbalance. I also want to add some more clinical variables to interpret these clusters even better. I want to study a technique called SMORT and use it in my analysis. I also want to use alternative cluster algorithms like Gaussian mixture, DB-scan, and see how they perform. I also plan to use supervised model techniques like random forest XCBoost to link clusters with survival drivers. And here are the references. This is the end of my presentation. Thank you, Dr. Banerjee, for this opportunity and teaching this wonderful course.